Hi there, my highly valued and treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I'm a clinical pharmacist by profession and by training. I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for the healthcare sector workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I would like to humbly urge you to sit back and spare me part of your very precious time to share useful tips with you. Welcome. Our first question reads, AJO, a 65-year-old African patient, bought an OTC over-the-counter antacid containing polyvalent cations, calcium, magnesium, and aluminum, which he intends to take alongside his oral medications. So my question to you is, which of the oral medications listed below would most likely have its bioavailability or absorption grossly reduced by co-administering the medication alongside the antacid? Would it be paracetamol, metolazone, levothyroxine, or amlodipine? I'll give you 10 seconds to choose the correct answer from that list of 4. In my opinion, levothyroxine it will be. Now, levothyroxine has a carboxyl group on its chemical structure, which can acquire a negative charge upon the release of hydrogen ions. The negatively charged functional group can then interact with other positively charged cations to form a complex which results in a reduction of absorption of levothyroxine itself. I would like to emphasize that di- and trivalent cations such as calcium, aluminum, and iron can significantly reduce the bioavailability of levothyroxine, thus putting patient AJO at a risk for worsening or uncontrolled hypothyroidism. PK drug interaction studies with aluminum have shown that TSH concentrations increase from an average of 2.6 million units per liter to a staggering 7.19 million units per liter. And the normal range, as we know in most laboratories, is from 0.5 to 5 million units per liter. As such, the use of this di- and trivalent cation containing products and levothyroxine should be separated by 2 hours before or 4 hours after ingesting or taking levothyroxine, just as a by the way. So remind your patients of those small details when they co-administer levothyroxine alongside antacids, or other over-the-counter medications. Let's move to the next question, please. The diabetologist at your endocrinology clinic has decided to initiate a patient on semaglutide, which is also marketed as Rybelsus. My question to you is, which of the counseling points listed below would be appropriate for this patient? Would it be to take 4 ounces of water 30 minutes prior to any medication, food, or drink? Or would it be to take this medication with food without regard to other medications? Or would it be to take this medication, semaglutide, before any other medications? Or would it be to take semaglutide with 8 ounces of water or juice 30 minutes before medication or food? I'll give you 10 seconds to choose the correct answer. So I would settle for A and advise the patient to take semaglutide with 4 ounces of water 30 minutes prior to any medication, food, or drink. Now, semaglutide, which is also marketed as Rybelsus, is available in a special oral formulation. It also has a subcutaneous formulation in the market, which is marketed as Ozempic. Now, Rybelsus must be taken according to the directions in the manufacturer's package insert. This is relevant because Rybelsus is co-formulated with an absorption enhancer, which we call sulcaprosate sodium, abbreviated as SNAC, and this is majorly to allow for daily dosing. The recommendations for oral administration of this product include swallow whole, do not split, crush or chew. Another one is ingest Rybelsus with 4 ounces of water or less. And they emphasize take with water only. Another one is eat and take other medications 30 to 60 minutes after taking the dose, that is Rybelsus dose. And if patients wait longer to eat, absorption and possibly adverse events will tend to increase. So you should encourage them to stick to the 30 to 60 minute window. Now, Rybelsus has a low bioavailability when administered alone, so it is dependent upon sitting on the gastric mucosa to allow the SNAC to facilitate its absorption by actually a mechanism of locally increasing pH. That's just by the way. Let's move to the next question, and it reads, which of the anti-hyperglycemic drugs listed below used in the treatment of type 2 diabetes mellitus should be avoided in heart failure patients who are diabetic? Is it saxagliptin, rosiglitazone, exenatide, the extended release form, or glipizide? I'll give you 10 seconds to choose the correct answer. So rosiglitazone it is. Now, rosiglitazone is a thiazolidinedione. That's the class it belongs to. For the treatment of type 2 diabetes mellitus, it is known to cause or to worsen heart failure due to increases in fluid accumulation or plasma volume. It is contraindicated in patients with known heart failure, especially those in the New York Heart Association classes 3 and 4. Now, alternative C, exenatide, which is marketed as Bydureon, is contraindicated in patients with a history of or familial history of medullary thyroid carcinoma or with multiple endocrine neoplasia syndrome type 2. That occurs in literature. And alternative D, glipizide, is a sulfonylurea that is contraindicated in patients with diabetic ketoacidosis or a known cross-sensitivity to sulfonamide containing medications, but not to heart failure. So C and D would be wrong answers. Now, A, saxagliptin, which is marketed as Onglyza, is a dipeptidyl peptidase 4 inhibitor that is used in the management of type 2 diabetes mellitus, and it is contraindicated in patients with a non-hypersensitivity reaction to saxagliptin, not in the heart failure population. So that's just a by the way to justify why rosiglitazone or Avandia is the correct answer in this question. Let's move to the next question. TBT is a 69-year-old diabetic female patient who presents to the endocrinology clinic at your hospital. TBT has a poor renal function. Her estimated GFR in this visit is 25 ml per minute. She has an A1C of 9.6%. Her diabetes is poorly controlled, and she doesn't experience polydipsia or polyuria from your conversation with her. Now, the endocrinologist treating her would like to achieve an A1C of below 8%. And this lady has a BMI of 28 kilograms per meter squared. So my question to you is, which of the recommendations below would you make to this endocrinologist? Would you advise him to initiate insulin therapy, to initiate liraglutide, to initiate canagliflozin, or to initiate linagliptin? I'll give you 10 seconds to choose the correct answer. Personally, I would recommend he initiates liraglutide. Now, the American Diabetes Association Standards for Diabetic Care recommends starting a glucagon-like peptide 1 receptor agonist, for example, liraglutide prior to insulin therapy. Liraglutide has been shown to have beneficial effects in patients with chronic kidney disease, and it may help with weight loss as well. That appears in literature. Now, alternative C, canagliflozin shouldn't be used if a patient's eGFR falls below the 45 ml per minute mark. Now, if I remember well, our patient's value is at 25. So, canagliflozin is a no-no for this particular patient. That makes alternative C wrong. Now, insulin therapy is considered first line in cases where the A1C is above the 11% mark, or if the patient has evidence of catabolism such as weight loss, polyuria, polydipsia. Those ones suggest insulin deficiency in a patient. And I would just like to add that insulin therapy is also first line in the case of type 1 diabetes mellitus, or in cases where this is a possibility. And then linagliptin, which is alternative D, alone, in my opinion, will not sufficiently reduce TBT's A1C to the goal we are aiming for, which is below 8%. Linagliptin is a DPP4 inhibitor with an average A1 reduction of between 0.4 and 0.8%, and that applies to the DPP4 inhibitor class as well. And I would just like to add for your information that common ADRs of the GLP-1 receptor agonists include nausea and vomiting, and it is important to start at a low dose and then titrate upwards till you achieve your goal. The GLP-4 inhibitors should not be used in patients with a history of pancreatitis or gastroparesis, just for your information. Let's move to the next question, please. Your endocrinology clinical team diagnoses an obese 15-year-old female patient with type 2 diabetes mellitus 120 days ago. They diagnosed it 120 days ago and put him on Metformin ER at a dose of 2,000 milligrams daily in 2 divided doses after breakfast and dinner. His A1C is 8.5 today in this particular clinic visit. So my question to you is, which of the antihyperglycemics listed below would you add to this patient's metformin regimen today to achieve the targeted A1C goal? Would you add glipizide ER at a dose of 5 milligrams once daily orally? Or would you add liraglutide at a dose of 1.2 milligrams orally? Or would you add pioglitazone taken orally at a dose of 30 milligrams once daily? Or would you add exenatide ER injected at a dose of 2 milligrams weekly? I'll give you 10 seconds to choose the correct answer. So in my opinion, B is the correct answer. Liraglutide is FDA approved for pediatric patients, and liraglutide up to doses of 1.8 milligrams once daily can be added to metformin or metformin plus insulin in this pediatric population. Now, if a patient experiences, for example, GI side effects with liraglutide, we advise you titrate by clicks, small amounts instead of marked doses for slower titration. That usually lessens this GI side effects. That's just a by the way for your information. So the next question reads, AKW, a 56-year-old female patient with type 2 diabetes mellitus, is currently taking metformin at a dose of 1000 milligrams after breakfast and after dinner. She also administers insulin glargine as her basal insulin at a dose of 30 units subcutaneously in the evening, and she also injects insulin aspart as her bolus insulin in doses of 10 units subcutaneously thrice daily before breakfast, before lunch, and before dinner. Her average morning fasting blood glucose is 155 milligrams per deciliter. Now, AKW's pre-meal blood glucose before lunch and before dinner consistently average values of 120 milligrams per deciliter, and her A1C is below 7%, though currently it is 7.3. So my question to you is, which of the medication changes proposed below would best improve her overall glycemic control? Would it be an addition of glipizide 5 milligrams before dinner to her current regimen? Or would you consider increasing the insulin glargine to a dose of 33 units every evening? Or would you increase the metformin dose to 1000 milligrams every morning after breakfast and 2000 milligrams every evening after dinner? Or would you consider increasing the pre-breakfast insulin aspart to a dose of 12 units administered subcutaneously, up from the 10 units level? I'll give you 10 seconds to choose the correct answer. I would opt to increase the insulin glargine to a dose of 33 units every evening, and I'll tell you why. When evaluating AWK's glucose log to determine which readings are uncontrolled, we established that her before breakfast glucose levels are elevated above the goal, which is 80 to to 130 milligrams per deciliter. Now, her readings before lunch and dinner are within goal in my opinion. Now, the next step I would take is to determine which medication change could help improve the morning fasting glucose readings. Now, increasing her evening long-lasting, or what we call the basal insulin, will help improve her morning fasting blood glucose readings. Now, increasing metformin to 2000 milligrams after dinner would exceed the maximum recommended daily dosage of metformin, which is a total of around 2500 milligrams daily, according to many endocrinologists. Now, increasing her insulin, the breakfast insulin aspect, to 12 units would decrease her before lunch blood glucose readings, in my opinion. And when you look at the text, they are already at goal. They fall between the 80 to 130 milligrams per deciliter bracket. Therefore, this isn't a necessary adjustment in the regimen. It isn't necessary to add a sulfonide urea either when a patient is on insulin aspart already as part of a diabetic regimen, since this combination would, in my opinion, increase the risks of hypoglycemic episodes. And such a combination also, in my opinion, increases the patient's pill burden unnecessarily. Now, for an A1C goal of less than 7, preprandial glycemic target ranges from 80 to 130 milligrams per deciliter. Now, for an A1C goal of less than 7, the postprandial plasma glucose should be less than the 180 milligrams per deciliter mark, just for your information as you manage such patients. Let's move to the next question, please. It reads, Madam L.W.A., a 29-year-old female patient, presents to your endocrinology clinic. She has a past medical history of Graves' disease, which is well controlled on Methimazole. She informs the clinical team she found out she is expectant, pregnant, she has conceived, and she seeks to know what action she should take with regard to her management of the Graves' disease. So my question to you is, which of the recommendations below would you make to Madam L.W.A.? Would you advise her to hold Methimazole and switch to propyl thiouracil for the first trimester, and then switch back or revert back to the Methimazole after the end of the first trimester? Or would you tell her to continue with her Methimazole therapy? Or would you discontinue Methimazole and schedule an elective or an urgent thyroidectomy within the next 14 days? Or would you discontinue Methimazole and schedule radioactive iodine ablation within the next 2 weeks? I'll give you 10 seconds to choose the correct option. I would advise this patient to hold the Methimazole, to switch to propyl thiouracil for a whole of the first trimester, and then revert back to Methimazole after the first trimester is complete. Now, according to the most recent American Thyroid Association and the AACE hyperthyroid guidelines, propyl thiouracil is preferred, is actually the anti-thyroid drug of choice in the first trimester of pregnancy, after which they recommend patients should revert back to Methimazole. Now, Methimazole can cause rare teratogenic effects such as aplasia cutis and esophageal atresia. Now, the US FDA recently recommended that PTU, propyl thiouracil, be reserved for patients who are in their first trimester of pregnancy and who are allergic to or intolerant to methimazole. Thyroidectomy, which was one of the propositions C to be specific, should only be considered when necessary and should be performed during the later part of the second trimester if feasible and possible, due to the fact that some of the anesthetic agents used in surgery can have teratogenic effects on the fetus, and they can even increase chances or risks of fetal loss in the first trimester itself, and they even increase chances of preterm labor in the third trimester, to be specific. Now, radioactive iodine ablation is a total no-no. It's contraindicated in pregnancy, so I would not opt for that option. Let's move to the next question, please. It reads, Mr. G.S.O, a 24-year-old male patient, presents to your endocrinology clinic. He is diagnosed with type 1 diabetes mellitus. Some of his pertinent blood glucose readings include a morning fasting plasma glucose of 190 milligrams per deciliter. His renal function is within normal limits, and this patient weighs 84 kilograms. So my question to you is, which of the insulin regimens listed below would suit this particular patient? Would you opt to prescribe 42 units of insulin glargine as the BCPS in the evening and 7 units of insulin aspart thrice daily before breakfast, lunch and dinner? Or would you prescribe 42 units of insulin glargine in the evening and 42 units of the same thrice daily before meals? Or would you prescribe 21 units of insulin glargine in the evening and 7 units of insulin aspart thrice daily before breakfast, lunch and dinner? Or D, would you opt for insulin glargine at a dose of 42 units in the evening and 21 units before each meal? I'll give you 10 seconds to choose the correct answer from that list of 4 options. So I would opt to prescribe 21 units of insulin glargine, the basal insulin, every evening and supplement with 7 units of insulin aspart before breakfast, before lunch and before dinner. Now, G.S.O's total daily insulin, which we abbreviate as TDI, requirement is calculated as his weight, which is 84 kilos times 0.5 units per kilo per day. That gives you a total requirement of 42 units per day. Now, we recommend you follow the rule of 50 by 50, and half of the TDI becomes 42 over 2, which is 21 units. That should make up the basal insulin requirement. So that gives us 21 units of insulin glargine, and the other half accounts for the bolus requirements, which must be split into 3 equal portions before the meals. And that gives you a balance of 21 divided by 3, which is 7. In other words, you should administer 7 units before breakfast, before lunch, and before dinner, and a total of 21 units of the basal insulin, which is insulin glargine. So I'll repeat again. I would recommend you administer 7 units of insulin aspart before breakfast, before lunch and dinner, and a total of 21 units of insulin glargine at night, at bedtime. So we are supposed to use a weight-based estimate to calculate this value if a patient is insulin naive. Now, for such a case, the TDI should be 0.3 to 0.6 units per kilo per day. That's why I opted for a middle figure, which is 0.5 for ease of calculation. Let's move to the next question, please. It reads, Mrs. J.I.K., a 36-year-old female patient, was treated at your hospital for polycystic ovarian syndrome with metformin, to be precise, with the aim of inducing ovulation. She desires to have a baby. She is in the second trimester of pregnancy. She has gestational diabetes, which was diagnosed after taking the 75 grams of oral glucose tolerant test. And she tells you she exercises daily and follows a diabetic friendly diet. Now, Madam J.I.K.'s morning fasting glucose readings range from 100 to 120 milligrams per deciliter. Her glucose readings 2 hours after meals are typically between 150 and 180 milligrams per deciliter. Now, J.I.K. inquires if she can restart the metformin because she tolerated it well prior to her pregnancy, and her mother also takes it for her type 2 diabetes mellitus. Her renal function is within normal limits. She has a GFR that is above the 60 ml per minute mark at the moment. So my question to you is, which of the treatment recommendations listed below would you make for Madam J.I.K.'s case of gestational diabetes mellitus? Would you recommend she restarts metformin? Or would you advise her to continue lifestyle changes? Or would you recommend she initiates insulin therapy? Or would you settle for dual therapy with metformin and glyburide? I'll give you 10 seconds to choose the correct answer. Personally, I would recommend she initiates insulin therapy. Now, insulin therapy is the preferred treatment of choice for gestational diabetes. Insulin doesn't cross the placenta to a measurable extent, making it a safe option in pregnancy. Now, insulin therapy coupled with lifestyle changes has been demonstrated to improve prenatal outcomes in several randomized studies. Now, lifestyle changes alone, that is option B, wouldn't be appropriate for our patient in this case because she isn't meeting the glycemic targets for gestational diabetes at all. Remember, fasting glucose readings should be less than 95 milligrams per deciliter, and the 2-hour postprandial glucose readings should be below the 120 milligrams per deciliter mark in this cohort of patients, the pregnant ones. Now, although lifestyle changes are essential as a component for the management of gestational diabetes, medication should be added when treatment goals aren't achieved, like in the case of this lady. I would just like to remind you that metformin isn't indicated as first-line treatment for gestational diabetes because it is known to cross the placenta, and data on safety of the offspring is still lacking. Metformin may also increase the risk of prematurity. You might have preterm babies being delivered, so I would not advise a lady to reinitiate metformin when expectant. Now, dual therapy with metformin and glipizide isn't recommended in pregnancy. Remember, the sulfonylureas such as glipizide are known to cross the placenta, and they have been associated with an increased risk of neonatal hypoglycemia, which can be lethal. There is insufficient data or evidence to recommend this combination in pregnancy, so I would not opt for alternative D at all. Now, glycemic targets are stricter in pregnancy compared to the non-pregnant individuals. That is why it would be necessary to administer some form of medication and not stick to lifestyle changes at all alone in pregnancy. Now, we should aim for the following gestational targets recommended by the 5th International Workshop on Gestational Diabetes Mellitus. They recommend a fasting of less than 95 milligrams per deciliter, which is equivalent to 5.3 millimoles per liter, and either a 1 hour postprandial of less than 140, which is equivalent to 7.8 millimoles per liter, or a 2 hour postprandial which is below the 120 milligrams per deciliter mark, which is equivalent to 6.7 millimoles per liter. Those would ensure safe pregnancy and healthier infants would be born. Let's move to the next question, please. Madam C.A.O., a 35-year-old female weighing 73 kilos, is in her 8th week of pregnancy. Her lab results reveal that she has hyperthyroidism due to Graves' disease. She reports having heat intolerance and anxiety, which she initially attributed to pregnancy and increased stress at her workplace. My question to you is, which of the treatment regimens listed below would be the most ideal for Madam C.A.O.? Would you opt to put on Methimazole 10 milligrams orally thrice daily, or would you prescribe propylthiouracil PTU at a dose of 100 milligrams orally thrice daily, or would you settle for 100 micrograms of levothyroxine administered orally once a day after breakfast, or would you settle for 60 milligrams of propranolol administered once daily? I'll give you 10 seconds to select the best answer from that list of 4. I would opt to prescribe and initiate 100 milligrams of propylthiouracil PTU administered orally thrice daily. Now, according to the American Thyroid Association guidelines, for Graves' disease during pregnancy, patients should be treated with the lowest possible dose of drugs needed to keep the mother's thyroid hormone levels slightly above the normal range. Don't drive them too low. The current recommendation is to use propylthiouracil in the first trimester in order to avoid teratogenesis, which is common when methimazole is used. Now, the initial dosage range for PTU is 300 to 600 milligrams orally per day in 3 divided doses. So 100 milligrams TDS orally would, in my opinion, be the lowest dose for initial treatment in this lady's case. Remember, patients should be switched to methimazole for the remainder of the pregnancy, that is trimesters 2 and 3, in order to avoid hepatotoxicity. Remember, the downside of using PTU is the high chances of causing hepatotoxicity. Now, methimazole is known to be less hepatotoxic than PTU. That's just for your information. Now, option C, levothyroxine, is indicated as the drug of choice in pregnancy for patients with hypo, not hyperthyroidism. Hypothyroidism. It would be inappropriate in this case of patient CAO because she has hyper and not hypothyroidism. Now, alternative D, propranolol, would be a good adjunct option. It has been shown to partially block the conversion of T4 to T3 and may assist with anxiety experiences in such patients. But in my opinion, it isn't first line for hyperthyroidism treatment. Now, use of beta blockers in pregnancy may also cause adverse effects, such as they may increase, in my opinion, placental perfusion and even fetal bradycardia. Remember, PTU is 10 times less potent than methimazole, so it may have fewer negative adverse effects, especially during the first trimester. Those are just by the ways to justify why in my opinion propylthiouracil would be a safer option. Let's move to the next question, please. Patient TGG, an older adult patient, is admitted to the ICU at your hospital after a road traffic accident. On day 2 of his admission, he is noted to have palpitations, high fevers, and anxiety. This patient has a past medical history of GERD and hypertension, and he currently takes hydrochlorothiazide at a dose of 25 milligrams once daily to manage the hypertension, and famotidine at a dose of 20 milligrams orally twice daily on an empty stomach to manage the GERD. Some of the pertinent labs include sodium levels of 135, potassium of 3.7, chlorides of 97, bicarb of 25, BUN of 21, glucose is 134 milligrams per deciliter, serum creatinine is 1, WBC is 15.6, the PCT is 2.5 nanograms per ml, and the TSH is undetectable. The free T4 is 12 nanograms per deciliter, and cortisol levels are 15 micrograms per deciliter. Some of his vitals include systolic blood pressure of 168, diastolic 96, the heart is revving, the heart rate is 128 beats per minute, and the body temperature is 102.9 degrees Fahrenheit. So my question to you is, which of the therapies listed below would suit Mr. TGG the most, basing on the lab results we've just brushed through? Would it be the use of 60 milligrams of methimazole every 6 hours orally, or would you consider propylthiouracil at a dose of 500 milligrams orally once, followed by 250 milligrams orally Q4 hours, or would you settle for 300 micrograms of levothyroxine infused IV once, followed by 100 micrograms administered IV once daily, or would you consider using what we call SSKI, saturated solution of potassium iodide, at a dose of 5 drops every 6 hours orally? I'll give you 10 seconds to choose the correct answer. I would opt to administer 500 milligrams of propylthiouracil as a loading dose, and then switch to 250 milligrams every 4 hours orally. Now, propylthiouracil is the preferred initial therapy for the management of thyroid storm. It blocks new thyroid hormone production and blocks the peripheral conversion of T4 to the more active form, which is T3. Now, methimazole blocks thyroid hormone synthesis, but unlike PTU, propylthiouracil, it doesn't block the conversion of T4 to T3, which is more active. Now, the recommended methimazole dose in thyroid storm happens to be 60 to 80 milligrams per day, not 60 QID. So that dose in alternative A would be a gross overdose. Wrong answer. Now, this patient has hyperthyroidism, and exogenous thyroid hormone supplementation would further worsen Mr. TGG's thyrotoxicosis. I would not opt to treat with levothyroxine at all. Now, SSKI shouldn't be administered first in thyroid storm. It should be administered at least 1 hour after the administration of PTU or methimazole. Now, if it's administered prior to the other two, PTU or methimazole, it can stimulate the thyroid hormone production and further worsen this situation of thyrotoxicosis. So I would not opt for D either. And the American Thyroid Association guidelines for diagnosis and management of hyperthyroidism outline a multimodal approach for the management of thyroid storm. Now, patients should receive therapy that decreases thyroid hormone production or secretion and at the same time prevents the peripheral effects of excess thyroid hormone. Now, steps should be taken to correct any systemic decompensation, to identify and to treat precipitating events, and to establish maintenance therapy. Now, propranolol, just for your information, also inhibits what we call the type 1 deiodinase, which prevents the conversion of T4 to T3. Glucocorticoids, on the other hand, may be used as well to prevent the conversion of T4 to T3 and to treat a potential concurrent adrenal insufficiency, which may also occur in some cases. Now, both PTU and methimazole may be crushed and administered via an NG tube if your patient in thyroid storm happens to be partially or unconscious. Now, because the duration of action of methimazole is less than 24 hours, it may be more effective when we divide the daily dose into several portions rather than administer it once daily for treatment of thyroid storm. That would just make your treatment outcomes better. That's just a by the way for your information. Let's move to the next question, please. Madam L.M.K, a 65-year-old female patient, is admitted to your ICU for shortness of breath and altered mental status. She has a past medical history of hyperthyroidism and severe persistent asthma. Underline asthma there. Now, some of her home medications include methimazole at a dose of 10 milligrams once daily. She inhales budesonide co-formulated with the formoterol 160 mics/4.5 micrograms at a dose of 2 puffs twice daily. She also inhales salbutamol PRN when she experiences shortness of breath. And this patient admits she quit taking all her medications 14 days ago. Her pertinent labs today include sodium levels of 132, potassium of 4.9, chloride of 99, bicarb of 25, a BUN of 15, serum creatinine of 1.3, WBC of 14.2, a TSH of 0.01 million units per liter, and her free T4 is 14 nanograms per deciliter. The cortisol is 11 mics per deciliter. Some of her vitals include a systolic of 150, diastolic of 90, with a heart rate of 90. Her body temperature is 103.1 degrees Fahrenheit. So my question to you is, which of the adjunctive therapies listed below would best suit Madam L.M.K. now? Would you opt to manage her with 10 milligrams of propranolol taken orally thrice daily? Or would you treat her with 325 milligrams of aspirin taken every 4 hours when feverish? Or would you recommend 1 to 2 tablets of paracetamol 500 milligrams every 4 hours when feverish? Or would you prescribe 0.1 milligrams of fludrocortisone taken orally once daily? I'll give you 10 seconds to choose the correct answer from the list of 4. Personally, I would settle for 1 to 2 tabs of paracetamol taken Q4 hours when the patient is feverish, and the reason is thyroid storm usually presents with pyrexia, which should be managed with paracetamol and or cooling agents. Now, aspirin, in my opinion, isn't an appropriate antipyretic agent for thyroid storm, since we know that salicylates may worsen thyrotoxicosis, and the reason why is they increase the thyroid hormone levels by displacing T4 and T3 from thyroxine binding globulin. So I would not opt for alternative B at all. Now, propranolol is recommended for the management of adrenergic related signs and symptoms associated with the thyroid storm. However, we've been told this is an asthmatic and the asthma is persistent. Now, considering L.M.K's severe asthma, the use of an unselective beta blocker like propranolol wouldn't be preferred. It would exacerbate the asthma. Then alternative D, fludrocortisone, isn't appropriate. We know that glucocorticoids such as hydrocortisone or dexamethasone are recommended by guidelines for the management of thyroid storm. They are thought to be beneficial by preventing adrenal insufficiency. They also block conversion of T4 to T3, and they can also have a positive impact when it comes to managing fevers. Now, fludrocortisone is a mineralocorticoid which would only be appropriate if this was a case of Addison's disease. Unfortunately, it is not. Now, thyroid storm, just for your information, is a medical emergency that requires a multimodal approach. Now, patients will often present with elevated temperatures, which must and should be managed with cooling blankets and with paracetamol. Now, all beta blockers should be avoided in patients with acute decompensated heart failure unless the likely etiology is related to hyperthyroidism induced tachycardia. That's just a bonus for your information. Let's move to the next question, please. It reads, which of the medications listed below can cause both hypothyroidism and hyperthyroidism? Is it lithium carbonate, amiodarone, propranolol, or PTU, propyl thiouracil? I'll give you 10 seconds to choose the correct answer. Amiodarone it is. Now, amiodarone happens to be a class 3 antiarrhythmic drug which contains very high amounts of iodine in each dose we administer, approximately 37%. And this can initially provide the thyroid gland with a sufficient iodine to to iodinate thymoglobulin proteins to make T3 and T4. However, too much iodine delivered to this gland can also suppress the thyroid function and lead to a suppression of the synthesis of those two hormones, T4 and T3, and that can lead to a hypothyroid state. Now, propranolol, alternative C, is a non-selective beta blocker that is sometimes used in the treatment of hyperthyroidism because of its ability to inhibit peripheral conversion of T4 to the more potent form T3. Now, propylthiouracil is used in the treatment of hyperthyroidism, and it acts by inhibiting the synthesis of thyroid hormone, thereby causing a hypothyroid state. And those many words clarify why B, amiodarone, is the correct answer to this question. Let's move to the next question. A 13-year-old adolescent girl, female, is brought to your endocrinology clinic by the mother. This girl has a chief complaint of anxiety and heat intolerance. Now, the mother reports that her daughter has lost weight despite not having changed her daily routine. Some of her pertinent labs include a TSH of 9.8 million units per liter, while we know that the normal range is anything from 0.4 to 4 million units per liter, so it's pretty high. The free T4 is 0.72 nanograms per deciliter. The normal range is from 0.7 to 1.9 nanograms per deciliter. And there's also a presence of thyrotropin stimulating antibodies, what we abbreviate as TSAB. Now, your endocrinologist on duty diagnoses her with Graves' disease. So my question to you is, which of the regimens below would be the best for this adolescent girl now? Would you initiate on propylthiouracil, methimazole, radioactive iodine, or would you settle for a thyroidectomy to get rid of the problem once and for all? I'll give you 10 seconds to choose the correct answer. I would settle for methimazole. Now, based on the labs and antibody presence, this girl should be treated for Graves' disease. Now, some children will go into remission following a 1 to 2 years of anti-thyroid drug treatment. And I'd just like to emphasize that the methimazole is considered first line for most children and adolescents. So that makes it the correct answer. Now, alternative C, radioactive iodine, is effective for the treatment of Graves' disease in pediatric patients, but in my opinion, it may be controversial due to the concerns of thyroid cancer in this population. The risk seems to be higher in patients below the age of 5, and it declines over time. The older they grow, the lower the chances. So I would not opt for C. Now, propylthiouracil, which is A, may be used in children, but it comes with a high and unacceptable risk of hepatotoxicity in this population. Now, methimazole is more potent and has a longer half-life and less tendencies to cause hepatotoxicity than PTU, propylthiouracil. I'd just like to add that a short course of propylthiouracil should be only considered in exceptions when, say, an adolescent or a child has a reaction to methimazole and you are in a situation where prompt surgery or radioactive iodine treatment is not available. That's the only incidents where I would opt to risk and use PTU. Now, most children will eventually require radioactive iodine or surgery, but these are not considered first-line modalities. Now, if remission isn't achieved following methimazole therapy, radioactive iodine or surgery may be considered. I would like to add that thyroidectomy may be effective for the treatment of Graves' disease, but it has been associated with higher complication rates, especially in children, than adults. And the only time I may choose it as definitive, as first line, is when definitive therapy is necessary. That's just a by the way. So let's move to the next question. It reads, WRO, a 71-year-old female patient who was found unconscious at home is brought to your accident and emergency department. You are told yesterday her primary care physician diagnosed her with pneumonia. Her past medical history includes an MI that occurred 48 months ago. She also suffers from atrial fibrillation, dyslipidemia, and hypothyroidism. Some of the home medications she takes include 81 milligrams of aspirin administered once daily, 200 milligrams of amiodarone, 40 milligrams of rosuvastatin at night, 50 micrograms of levothyroxine taken in the morning. She weighs 60 kilograms and she's 5'4". My question to you is, which of the therapies listed below would be the most appropriate for Madam RWO's thyroid disturbance? Would it be 100 micrograms of levothyroxine taken orally once daily in the morning, or would it be 200 mics of levothyroxine administered as IV start, followed by 75 mics IV once daily, or would it be 5 mics of liothyronine administered IV once, then followed by 2.5 mics IV thrice daily, or finally would it be 20 mics of liothyronine administered orally once daily, followed by 10 mics administered IV 3 times daily, in addition to 100 mics of levothyroxine administered IV once daily? I'll give you 10 seconds to choose the correct answer. I would opt to administer 200 mics of levothyroxine IV, followed by 75 mics IV once daily. And I'll tell you why. WR's presentation and lab findings, in my opinion, are consistent with the severe form of hypothyroidism, which I may call myxedema coma to be specific. Now, the American Thyroid Association guidelines recommend administration of IV levothyroxine for cases of myxedema coma such as this one, and the recommended loading dose according to those guidelines, if I remember well, is 200 to 400 mics administered start, followed by a maintenance dose of 1.2 mics per kilo administered IV once daily. Lower doses are recommended in the elderly patients with a history of coronary artery disease or arrhythmia, and in patients with low body weights. Now, levothyroxine 100 mics orally once daily is the correct treatment for myxedema coma, but the oral route of administration isn't appropriate. The dose is okay, the route is wrong. Remember, gastric atony is a potential complication of myxedema coma, and thus oral therapies would have decreased absorption. You would have subtherapeutic levels. Now, patients with severe hypothyroidism will be unable to fully convert levothyroxine to T3, and therefore clinicians recommend the addition of T3 when managing myxedema coma, because they don't effectively convert T4 to T3. Now, the doses in alternative D are too large, in my opinion, considering that this patient is elderly. She has a history of CAD, coronary artery disease. The liothyronine dose is the highest in the recommended dosing range, which is 5 to 20 mics loading dose, followed by a maintenance dose of 2.5 to 10 mics TDS. Now, the levothyroxine dose is dosed for oral formulation, which is 1.6 mics per kilo per day, rather than the IV formulation, which should be 1.2 mics per kilo per day. I would just like to add that myxedema coma is a rare complication of severe hypothyroidism that is considered to be a medical emergency. So you treat it with the urgency it deserves. It is usually precipitated by a medical illness. Now, this lady had an infection. Infections are known to exacerbate it. Remember, we've been told she was diagnosed with the pneumonia the day before admission. Stroke and heart failure can also exacerbate myxedema coma. Just like to add that a high TSH with low T3 and free T4 levels are indicative of hypothyroidism. Then hypothermia and unconsciousness are considered to be cardinal features of myxedema coma, but patients may present with other features consistent with a hypometabolic state, which may include, for example, hypoventilation, gastric atony, and bradycardia. Now, I would like to refer you to the 2014 American Thyroid Association guidelines, which recommend myxedema coma be managed by administration of a loading dose of levothyroxine in a range of 200 to 400 mics IV, followed by the initiation of a maintenance dose, which is usually 1.2 mics per kilo per day IV, not oral, IV, until the patient is able to take replacement therapy orally. Now, the oral replacement therapy should be dosed at 1.6, not 1.2, 1.6 micrograms per kilo per day of the oral form. Now, the guidelines make a weak recommendation for using liothyronine in combination with levothyroxine. It is possible that the conversion of T4 to T3 may be impaired, and therefore the addition of T3, as I said earlier, may be helpful in these patients because they don't effectively convert T4 to T3. Now, the levothyroxine dose should be decreased by between 50 and 75% when converting from the oral route to the IV formulation. That is mainly to account for the differences in bioavailability. Remember, the IV route is more bioavailable than the oral route. That's just a by the way. Let's move to the next question. Madam T.O.O., a 68-year-old female patient, presents to your endocrinology clinic with a past medical history of type 2 diabetes mellitus. She's had an MI a year ago, to be precise. Currently, she takes atorvastatin, the high-intensity dose atorvastatin, at a dose of 80 milligrams at night, and she tells you she has experienced no side effects so far. She is comfortable and tolerating the high dose intensity atorvastatin. Some of her pertinent lab results include an A1C of 7.3%, a TC of 210, HDL of 40, LDL cholesterol of 74, and a TG of 480. So my question to you is, which of the therapies listed below would you recommend to further decrease TO's atherosclerotic cardiovascular disease risk? Would you opt to prescribe icosapent ethyl, which is called Vascepa, at a dose of 2 milligrams twice daily? Or would you settle for niacin 1 milligram HS? Or would you settle for the omega-3 2 milligrams twice daily? Or would you administer fenofibrate 48 milligrams once daily? I'll give you 10 seconds to choose the correct answer. Settle for Vascepa 2 milligrams twice daily. Now we know that Vascepa, which is icosapent, can be added to statin therapy in patients with moderately elevated TGs. That is a range of 135 to 499. And it demonstrated, when added in trials, a reduction in a composite of cardiovascular death, non-fetal MI, non-fetal stroke, coronary revascularization, or even unstable angina in what we call the reduce it trial, REDUCE-IT. I would recommend you read an article on that trial. Now, alternative C, Lovaza, which is the omega, doesn't have clinical trial evidence to demonstrate a reduction in cardiovascular events in combination with statin, so I would not rush into recommending it. And niacin hasn't demonstrated additional cardiovascular benefit in patients with controlled LDL. I'll refer you to the AIM-HIGH trial, AIM-HIGH. This trial was stopped prematurely or early due to lack of benefit. Then the fibrates, Trica in this particular case, in combination with statins, have demonstrated a risk for elevated LFTs. The liver would take a hit. They've also demonstrated an increase in the risk of rhabdomyolysis without a consistent reduction in cardiovascular events. So I would not opt for that one either. The risks would not justify the benefits. Let's move to the next question, please. Your endocrinology team is evaluating a 62-year-old patient for a thyroid disorder, which they suspect due to the pertinent labs, which show a TSH less than 0.1 million units per liter, the free T4 of 5.1 nanograms per deciliter with an elevated RAIU. My question to you is, which of the medications listed below would be the most appropriate for this patient's disorder? Would it be levothyroxine, methimazole, sodium iodide, or thyroid? I'll give you 10 seconds to choose the correct answer. I would opt to recommend methimazole. Now, based on the thyroid workup above, this female patient is experiencing thyrotoxicosis, probably a case of Graves' disease, and thus she needs medication to reduce the thyroid hormone T4 or T3 levels. We know that methimazole is the only agent in the list above that is recommended for longer term use for hyperthyroidism. Now, alternative C, sodium iodide and similar agents can be used to rapidly bring a patient into what we call a euthyroid state, especially just prior to surgery. But in my opinion, it isn't used for long-term suppression, as the hyper-functioning thyroid gland will eventually escape the inhibitory effects of sodium iodide therapy within a matter of weeks, a few weeks to be precise. Now, levothyroxine and D, which is thyroid, that is a desiccated form of thyroid, are used as replacement therapies in hypothyroidism. Remember, our patient is suspected to have hyperthyroidism, so they have no place in her management. Let's move to the next question, please. It reads, EMA, an adult diabetic patient, has an elective bariatric surgery scheduled in 7 days' time, in a week to be precise. This patient has a history of diabetes mellitus. Currently, the patient takes 2,000 milligrams of metformin in 2 divided doses after breakfast and dinner. Apart from that, the patient is on dulaglutide at a dose of 1.25 milligrams administered subcutaneously weekly, and as basal insulin, the patient administers insulin degludec Tresiba at a dose of 20 units sub-Q at night. The patient also takes empagliflozin at a dose of 20 milligrams once daily. So my question to you is, which of the recommendations listed below would you make regarding the preoperative management of this patient's anti-hyperglycemic regimen? Would you advise the team to hold dulaglutide for the last dose prior to surgery, or would you recommend discontinuation of empagliflozin 3 days prior to surgery, or would you recommend that Tresiba be discontinued 24 hours prior to surgery, or finally, would you recommend discontinuation of metformin 2 days prior to surgery? I'll give you 10 seconds to choose the correct answer. I would choose to discontinue empagliflozin 3 days prior to surgery, and I'll tell you why. Empagliflozin and other SGLT2 inhibitors can precipitate diabetic ketoacidosis, especially when other risk factors that precipitate the same DKA occur. And some of these factors include surgery. So a patient undergoing surgery would be at least risk. Now, it is advisable to hold SGLT2 inhibitors 3 days prior to surgery to avoid the potential for diabetic ketoacidosis. Remember, SGLT2 inhibitors can be reinitiated when the conditions resolve. That's the conditions that may precipitate DKA. And what I have in mind here is when the patient stabilizes after surgery. Now, additionally, this patient, if I remember well, is scheduled to have bariatric surgery. Now, this kind of surgery may also be associated with post-operative dehydration that can lead to, for example, hypotension, syncope, and acute kidney injury. Now, all those three can be worsened by concurrent administration of SGLT2 inhibitors during the same period. Now, alternative A, dulaglutide, doesn't carry any special instructions related to surgical procedures. Now, since it is dosed weekly and has a low risk for hypoglycemia, I don't think dosing around surgery should be altered. It won't be affected majorly. Now, Tresiba, on the other hand, should be given to avoid hyperglycemia prior to surgery. Some providers will choose to administer, say, 80% of the basal insulin in the evening prior to surgery, but the regular dose may also be given. Now, prandial insulin would be stopped once the patient is in fasting states. Otherwise, there'd be no sugar to remove from the bloodstream. Now, for this patient, in this case, holding the insulin and continuing empagliflozin could significantly increase the risk of DKA, so I would not go that way. Now, in my opinion, metformin should be held on the day of surgery and until the patient is stable post-operatively. Now, I would like to remind you to consider such patients' occupations when prescribing SGLT2 inhibitors. Now, patients who have outdoor occupations, for example, that may result in excessive sweating and inability to maintain hydration could be at increased risk of SGLT2 inhibitors adverse effects. They may experience very serious hypotension when they are put on these drugs. That's just for your information. So, ladies and gentlemen who form my group of very highly esteemed viewers and listeners, that brings us to the end of part 39 of our pharmacotherapy MCQs. Now, if this video helped you in any way, I would like to kindly urge you to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I would like to humbly request you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. And I'm very thankful that you made time to view and to listen to this video. I highly appreciate your continued support and collaboration. And I look forward to interacting with you in part 40 of our MCQ series. Thank you for always being there for me.